So initially when we inspect, and once again inspecting side to side, put both arms out, we inspect from the front, we look for any signs of any type of wasting of the musculature, any type of scars around the elbow as well. Once again, comparing sides. It's very important to look from the side as well. Turn and face that way, please. Looking from the side, looking at the muscular volume and looking for scars, and looking from the back as well. Face that direction, please. And we can bring both elbows back into this position. And once again, look at the elbows from the back, from posteriorly as well. And from posteriorly, we can often inspect the medial aspect of the elbows as well. The next part of the examination is palpation. And so once again, when examining the elbow, we're thinking about the anatomical structures that we're palpating. So usually we start over the lateral side. We palpate the lateral supracondylar ridge of the humerus. We run down into the lateral epicondyle. We feel for the common extensor tendon. We run down to the radial head. We can often rotate and pronate and supinate the radius and feel the radial head moving underneath our fingers. We then go down to the posterior aspect of the radiocapitellar joint, run along the olecranon onto the triceps insertion, then we run to the medial aspect of the olecranon. We can also feel the ulnar nerve located behind the medial epicondyle, and I can feel that as a cord behind his medial epicondyle. Once I feel that ulnar nerve, I can flex and extend to see if the ulnar nerve does sublux around the medial epicondyle. Then I feel the medial epicondyle and also the common flexor musculature as well. The next step is to assess range of motion in the elbows, and it's very important to assess both active and passive range of motion. If we find a limitation of active motion, then we go ahead and assess passive motion. So the best way to assess for active range of motion is to compare side to side, and the easiest way to do that is as follows. So put both arms out. We can see that he has full and symmetrical active extension. Now come in and touch your shoulders. Full and symmetrical active flexion. Now bring your arms down to this position here. And now we're going to use his thumbs to assess his pronation and supination. Turn your palms up as much as you can. Full and symmetrical supination, and turn the palms in as far as you can. And once again, full and symmetrical pronation as well. A very common presentation for an elbow problem is pain on the outside of the elbow. And one of the most common diagnoses is known as lateral epicondylitis or tennis elbow. The way to diagnose that from an examination point of view is to look for tenderness. And the way to find the tenderness is to feel for the lateral epicondyle, and just anterior to the lateral epicondyle, if we push in that area, that will cause a lot of pain in that area as well. And the way to further make the diagnosis is to examine the elbow in full extension, straighten out your hand as far as you can, keep the wrist there, and don't let me push it down. And that should increase the pain in this area here. The reason that increases the pain is because the extensor carpi radialis brevis might have a small tear, and as we test that muscle, it worsens the pain at the level of the elbow. Another very common presentation for an elbow problem is a rupture of the distal biceps tendon. Usually happens in middle-aged men. And the way to assess for a rupture of the distal biceps tendon is to first of all inspect. And what we'd be looking for, particularly if it was a couple of days down the line, we'd be looking for bruising along the medial aspect of the forearm. Another thing to look for is proximal migration of the biceps muscle belly. Finally, we can also test for the biceps tendon, and the way to palpate the biceps tendon is to perform the hook sign. And the way we perform that is we flex the elbow up and we put our finger into the crease, and we come from the lateral side, and I should be able to hook my finger around the biceps tendon. So this patient has an intact distal biceps tendon. However, if it was ruptured, we wouldn't be able to palpate that biceps tendon. Another very sensitive way to pick up the rupture is to test for the power of supination. So first of all, we're going to pretend that his left side here is normal. So I ask him to keep his forearm in this position and to not let me twist it in. So keep it there, strong, 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 and I cannot overcome that. On this side, we're simulating a rupture. So when I test him on this side, he'll have some supination, but I'll be able to overcome it, and it might cause some pain as well. Keep it there strong, don't let me twist it in, and I can easily overcome his supination on that side. And that's what you'd expect to see with a rupture of the distal biceps tendon on the right side. After examining a shoulder or an elbow, it's very important to complete the examination by examining the cervical spine and also doing a neurological examination and a vascular examination of the hand and in particular of the radial, the median and the ulnar nerve. So that completes the examination of the shoulder and the elbow. We hope you gathered some information from this video tutorial. If I can reinforce anything, I'd say to you that it's always very important to compare sides and to always think about active and passive motion. The other important thing is to keep it simple. Always think about look, feel and move. And if you stick to those basics, you should be able to make accurate diagnoses for your patients.